Our next speaker continues our policy section of the conference. It's Maria Town, who is the president and CEO of the American Association of People with Disabilities. In this role, she works to increase the political and economic power of people with disabilities. She previously served as the director of the City of Houston's Mayor's Office for People with Disabilities, advocating for citizens with disabilities, and she was the senior associate director in the Obama White House Office of Public Engagement, managing disability community engagement and coordinating federal engagement. She has expertise in the areas of youth development, leadership, and promoting college and career readiness. And she's going to talk about Medicaid. What is it? Why is it important? And what does the reconciliation bill mean for the future? The reconciliation bill meaning HR 1, the federal bill, also sometimes referred to as the Big Beautiful Bill.
Hello, everyone. Clarissa, thank you for that introduction. Again, my name is Maria Town, and I serve as the president and CEO of the American Association of People with Disabilities. I'm a white woman with long brown hair, wearing a purple dress and red lipstick. And although we just met, I want to tell you about my childhood. So I was born with cerebral palsy, a developmental disability. And throughout a large part of my childhood, I received services and supports through a Medicaid waiver. And I'm from the state of Louisiana. The Medicaid waiver services helped my family and I. They supported me receiving in-home physical and occupational therapy. They provided my mother with respite support and services. And they allowed me to receive in-home personal attendant services, which were really critical as like many kids with physical and developmental disabilities. I had a lot of surgeries. So that in-home personal assistance support was extremely helpful as I recovered from many surgeries in childhood. And when I was about 10, the state of Louisiana changed their Medicaid program, and I went through a redetermination to figure out if I was disabled enough to continue needing these services. And ultimately, I lost my services. My family and I, we fought this decision. I remember having to go in front of a judge and walk. And again, at that time we lost, and so I lost access to physical therapy. I lost access to in-home personal attendant services, and my mom lost access to respite services. And the services that I used when I received a Medicaid waiver are just a few of the ways that Medicaid supports people with disabilities, daily lives, and ultimately our goals and dreams for the future. On this slide is a photo of me at my kindergarten graduation. I am kind of smiling embarrassingly. I'm wearing a blue mortarboard hat, and I have a posterior walker around the front of my body as a kind of, it was just the most convenient. I personally think I look very cute. But yeah, just a few years after this, I would lose my Medicaid. And so next slide. There we go. Why am I telling you all of this? Again, we just met. Why am I already telling you about a traumatic childhood memory? The One Big Beautiful Bill Act, or HR 1, was passed in July of 2025, and it makes many changes to Medicaid. One of those changes is that people getting Medicaid through the expansion program will have to go through a redetermination every 6 months. Another big change is that some states will start having to have work requirements or community engagement requirements for some people who get Medicaid. And you're hearing me say some people because these requirements apply specifically to the Medicaid expansion population, which I'm going to talk more about in a little bit. So what is a redetermination? A redetermination is a process where the state asks you to prove your disability in order to decide if you can get services. In order to go through a redetermination, you may need to get new assessments from doctors or other healthcare professionals, and you may also be required to participate in an interview. One of the things you're going to hear me say a lot in this presentation is that we don't actually know a lot of specifics right now because all of this is still being decided and determined, which actually creates an opportunity for all of us to influence the process and try to shape how these redeterminations work. And on this slide, there are kind of stock images of people with disabilities, documents, and healthcare providers engaged in conversation. What is a work requirement or a community engagement requirement? So the law itself, HR 1, refers to these requirements as community engagement requirements, but colloquially and in the disability community, we talk about work requirements. So the requirement is that individuals getting Medicaid through the expansion program must report at least 80 hours of activity per month to maintain Medicaid coverage. And the bill articulates qualifying activities that need to meet that 80-hour threshold. One is paid work, paid employment. Another is being enrolled in an education program at least half time, and that can include a certificate, technical program, or a degree program. A third set of qualifying activities is job training. And then the fourth is community volunteering. So that's volunteering with community organizations. And a failure to meet these qualifications or to report these qualifying activities accurately could mean that people will lose access to Medicaid. So what does this mean for California? California started Medicaid expansion in January of 2014. More than 5 million people in California gained coverage to Medi-Cal as a result of this action. As of August 2024, 14.9 million people, or almost 40% of Californians, are enrolled in Medi-Cal. Due to Medicaid cuts, the state gross domestic product of California could shrink by over 14 billion, and more than 120,000 jobs could be lost in 2026. Medicaid, in addition to providing services and supports and healthcare access for individuals, is also a funding lifeline for many hospitals and the direct support workforce. Hospitals, particularly rural hospitals, are being put at extreme risk of closure as a result of these Medicaid cuts. And on this slide is an image of the state of California with the counties in different colors. So what more does this mean for the state of California? And I'm sorry, I put this together for Louisiana as well. So the state of California is going to have increased administrative costs as a result of these redeterminations and work requirements. The state of California will have to check to see if people meet the work requirements or if they meet a set of exemptions when they apply for Medi-Cal or when they go through a redetermination. The state is going to have to look back on a month of activity when people apply or go through a redetermination. They could look back longer. Some states may choose to look back 3 months. If a state says that someone does not meet the requirements, the state has to inform that person, and individuals will have 30 days to meet the work requirements or community engagement requirements. And on this slide is an image of the California State House. Now, when we were doing a lot of advocacy to try to prevent these Medicaid changes in the One Big Beautiful Bill Act, or HR 1, what we heard from many elected leaders and policymakers is that people with disabilities were going to be exempt from these requirements. And in fact, many elected leaders told their constituents with disabilities that people with disabilities were going to be exempt. So why are we talking about this? Aren't people with disabilities exempt? It depends. All people with disabilities are not exempt from redeterminations or work requirements. So let's talk about what these exemptions are, how they work, and how, again, we can shape them moving forward. So HR 1 established a number of different exemptions for the Medicaid work requirements or community engagement requirements. The mandatory exemptions are parents, guardians, or caretakers of dependent children under age 13 or disabled people, people who are pregnant or receiving postpartum coverage, foster youth or former foster youth under age 26, people who are medically frail, and that's kind of the biggest exemption that relates to people with disabilities, people participating in substance use disorder programs, people who already meet the SNAP, Supplemental Nutritional Assistance Program, or TANF, Temporary Assistance for Needy Families work requirements, American Indians and Alaskan Natives, disabled veterans, people who are incarcerated or who are released from incarceration within 90 days, or people who are entitled to Medicare Part A or enrolled in Medicare Part B. Those are mandatory exemptions. There are also a set of optional hardship exemptions that states can choose to elect. These are short-term optional exemptions for people who maybe were in an inpatient hospital, nursing facility, or immediate care facility, someone who resided in a county with a federally declared disaster or emergency, people who resided in a county with very high unemployment, or someone who traveled outside of their community for an extended period for medical care for themselves or for a dependent. So what does medically frail mean? Again, the One Big Beautiful Bill Act, or HR 1, excludes people who are medically frail from work requirements. The bill did specify that medically frail includes the following groups: people who are blind, individuals with serious or complex medical conditions, those with substance use disorders or disabling mental health disorders, and people with physical, intellectual, or developmental disabilities that limit daily activity. Now, the other thing that the bill did was it allowed states to have discretion around how they define medically frail. And so even though the bill provides examples, states will still get to determine who is medically frail and who is not. And I want everyone to think back to 2021, when we had just gotten access to the vaccine for COVID-19. At the time, the Centers for Disease Control had a list of individuals who were at risk, at high risk of COVID-19. States were allowed and encouraged to prioritize people who were at high risk of COVID-19 for first access to the vaccine. I'm going to use my own disability as the example here. The CDC listed cerebral palsy as a very high risk condition for COVID-19, but not every state did. And there were many people who were very confused because in some states, folks with CP could get access to the vaccine first, and in other states, they had to wait much longer. And so even with these specific examples, states could still come up with their own list. And it will be important for disability advocates in California to try, and I'll say this again, but try to make these exemptions and this kind of question of who is medically frail as broad as possible. So when will all of these changes start? When will this happen? On June 1st of 2026, the Department of Health and Human Services will issue an interim final rule that states have to follow in order to implement the work requirements and redeterminations. And I forgot to mention, we are currently unsure about who will be exempt, if anyone, from the redeterminations, or if the list of exemptions for the work and community engagement requirements will be the same as exemptions for the redeterminations. So June 1st is when we're going to see this interim final rule. That's going to be a big day. Pay very close attention to what is in the interim final rule, because that will begin to take effect as soon as it is issued. It will not go through any kind of notice or comment period where You and I can voice our opinions and say how we think all these things should work. By September 30th, 2026, states are required to reach out to people on Medicaid about work requirements. So states are required to send a letter, to send an email, to make a phone call, post on social media to let people know that work requirements will be starting and how they will work and if they may or may not be exempt. Work requirements will start by January 1st of 2027, and that is not a very long time from now. Now, December 31st, 2028 is the longest amount of time that states have to request a delay in implementing these work requirements. So if a state is having issues figuring out how to administer all these new changes, how to manage all these programs, they can request for a delay in implementation to the federal government. And the latest that delay will be granted is December 31st, 2028. So the three key dates, though, June 1st of this year, September 30th of this year, and January 1st of 2027. So what can you do? One is get prepared. A big reason that disabled people and people in general lose access to Medicaid when requirements like this are implemented, which we have seen in two states already, is they lose access to health care because of administrative issues, because they don't have their documentation ready, because they experience delays in mail. So gather important documents that provide information about your disability and the supports and services that you need to thrive. For making sure you're ready for the work requirements or the community engagement requirements. If you work, if you volunteer, if you go to school, make sure that this is documented and begin pulling things together like timesheets, pay stubs, and hours trackers. Additionally, you can also speak out. And to Claudia's presentation, people power is essential right now. Continue to reach out to your elected officials at the federal level because they do and they can reverse these changes. You can also and should be reaching out to the California State Medicaid Director. Tell them what you and your community need to make communication and all of these processes accessible and fair. This can include putting information into accessible formats, offering assistance to fill out forms, and more, and encourage state officials to make these exemptions as broad as possible. That alone will help people stay connected to their healthcare and really keep people alive. Um, that ends my slideshow. And I think now we can go to questions.
Thank you so much. That was incredibly clear and helpful, and gives us a strong path. I want to start by, over the years, I've noticed that all public bureaucracies sort of work this way, that they promise the world, whether it's your health insurance or the regional center system or any other public bureaucracy where there's a negotiation for services and supports. And when the budget gets tight, they put more bureaucratic barriers in place to accessing the services, and then certain people and populations are able to jump through those hoops and others are not. So this is not unique to this bill or this is not unique to this bill or to Medicaid. However, it's what's unusual about it is how upfront they were that that's what they were doing. We're going to save Medi-Cal by creating bureaucratic barriers, by making it harder for caregivers, for people with disabilities, for other people to access these services. And so um, the response of the state bureaucracies is that it's probably not, even if people with disabilities end up being exempt or an individual ends up being exempt, the state is going to be put under financial pressure and therefore will probably do the same thing, create more bureaucratic barriers through the regional center system or other bureaucratic barriers to access other services in order to save money. So this will start a whole cascade of bureaucratic barriers in multiple systems that people with developmental disabilities rely on. Um, you talked about maybe we could reverse this. Maybe this doesn't actually have to come to be or to happen. Can you talk more about that?
Yes. So, again, Claudia mentioned in her presentation that rebuilding these federal agencies that have been torn apart will take longer than restoring Medicaid, and I agree with that assessment. These Medicaid cuts they happened with the stroke of a pen, right? When President Trump signed the legislation into law, and they could be undone just as easily. Um, one of the sort of um, while California has a huge kind of Medicaid population, it is the result of California's size generally. Most states, and in fact, many states with leadership that voted for these changes actually rely on Medicaid more to provide their citizens and residents with health care. And so we at AAPD and really at disability organizations across the country are continuing to implore legislators to protect Medicaid and to reverse these cuts. Um, Again, in addition to legislation that may fix some of these cuts, keeping those exemptions broad, like I mentioned, for work and community engagement requirements will prevent some harm from occurring. Um, and encouraging states to delay implementation of the work requirements, community engagement requirements, and redeterminations, again, will also minimize harm. I the data that we have coming out of Georgia, a state that has already implemented work requirements, shows that the state is actually losing money to implement this larger bureaucracy, and it's not um, the sort of savings that would come from cutting people off of healthcare are not happening. One of the common refrains in our advocacy work has been work requirements don't work. They don't encourage greater employment. They don't encourage a reduced sort of reliance on public benefits, and they actually cost states money. And elected leaders need to continue to hear that.
Okay, thank you. Um, Can you talk a little? I noticed that SSI was not people who qualified as disabled based on the requirements of Social Security income didn't appear to be on that list. Is that something that states can do, or can you talk a little bit about more about people who are on social supplemental security income or supplemental security disability income? Social Security disability income?
Yes. So Clarissa mentioned two programs that are run by the Social Security Administration. Supplemental Security Income. This program is actually both programs are federal programs that provide people with disabilities with cash assistance. SSI, there is an asset limit of $2,000 that has not been adjusted since 1984. And if SSI recipients go over that asset threshold, they will lose access to their SSI. And often, SSI benefits are tied to Medicaid benefits. So if someone loses their benefits, it's not just the monthly SSI payment, which can range. Um, it also often includes Medicaid. SSDI has higher income thresholds, and so the sort of the potential for crossing those thresholds is lower, and so there's usually less threatened, but it is still something to think about. So, Clarissa, you are right that they did not automatically exempt people with disabilities who receive SSI. That is something that we are encouraging states and the federal government to do, that CMS should be able to work with, CMS being the Centers for Medicaid and Medicare Services, should be able to work with the Social Security Administration to automatically exempt anyone who is currently receiving SSI or SSDI from the work requirements or community engagement requirements. States could do that as well, although because SSI and SSDI are federally administered programs, I'm hoping that we have more traction at the federal level for that kind of work. But again, at AAPD, we are trying to meet with CMS to help them. I don't know if that's the right word, but uh, to express what we think needs to be in the interim final rule. There are many disability coalitions that have had those meetings to help shape what's going to be issued in June. And then, similarly at the state level, there's a lot of those conversations going on with state Medicaid directors. I think part of when folks were originally working on HR1, the desire by some legislators was to actually use the definition of disability that is within Social Security as the exemption definition for people with disabilities for work requirements. And I think the reason that that was not done is it's actually not broad enough. The definition of disability within Social Security is fairly specific, and it is literally like the inability to work. Most Medicaid recipients actually do work. So I think they wanted to come up with a broader definition that would be more inclusive of a larger population.
Thank you. Um, en Enforcing work regulations means income, which is going to affect the SSI benefits as well.
Mhm.
Will there be no exemption to not count the wages based off this requirement?
We that makes sense, doesn't it? But we don't know yet. I mean, all of this is still, I mean, the details are really kind of up in the air. We're all waiting to see what CMS says. And there are some states, like Nebraska, is trying to comply with these requirements early. I hope that no other state does that. But we don't yet have guidance from CMS or from most states on how they will implement these work requirements. But I would hope um, that either people receiving SSI are automatically exempt, or that the whatever income that's generated as a requirement of fulfilling the work requirements is not counted towards the asset limit.
Um, it, it strikes me it's not like there's a lot of jobs out there. They're assuming there's
I,
going to be jobs for people with disabilities out there.
yeah, I mean, what a great point. And I think I didn't go into this example, but the look back issue is actually a big one. If a state decides that their look back period is 3 months instead of 1 month, and someone is out of work, for a couple of months, they get a job and they apply for Medicaid. If the look back period is 3 months, um, they will not fulfill the requirements because they have not been employed for a 3 month period. They may have only been employed for a couple of weeks. Similarly, if you have a disability like depression where it's episodic and or a chronic illness where you're experiencing a flare and the flare or a depressive episode prevents you from fulfilling 80 hours within a job that you have in a particular month, um, you will not meet the work or community engagement requirements and could lose your health care or not or be deemed ineligible. Um, and so even with the exemptions that are set, I think there are still a lot of people who will fall through the cracks.
Yes, yes, for sure. There was a question about how healthcare providers might be able to support their patients through the redetermination process. Is there certain verbiage that we should put in notes or documentation that will best support people who are going through the redetermination to try and ensure that they don't lose their Medicaid services?
That's a great question. And again, nothing that we can be too sure of right now. What I will say, and this goes against everything that is in me. Um,
Mhm.
what I will say is, I would actually point out in documentation, you know, how people are struggling. And I think this is hard, especially for providers who are supportive and strong disability allies. Um, the example that I'm thinking of is so as someone who is like relatively young, and if you see me sitting down, I may not appear very disabled. When I'm at the airport, um, and I use wheelchair assistance, oftentimes the people who are providing that assistance walk right past me because they assume I don't need it. And then I have to kind of engage in a dialogue where I try to convince them, like, no, yes, I am the passenger who needs this chair, I promise. In addition to having a dialogue, I often have to like get up and be as disabled as I possibly can be to show, no, I really do need you to assist me getting through the airport. And I think any kind of documentation you can provide where it's like, no, this person is struggling to um, to manage activities of daily living. This person does have difficulty completing these tasks. I think more of that needs to happen so that people can keep their services rather than less. And I don't like saying that, but I think it's true. Does that make sense?
Yes.
Yeah.
Yes. I people think I think when people say Medi-Cal or Medicaid,
Mhm.
people think about their health insurance, going to their primary care doctor, their specialist, they think about medical care.
Mhm.
But because Medicaid is called so many different things
Yep.
and different states have special agreements with called waivers that are through the Medicaid program to pay for things that normally that aren't um, acute medical care, that aren't things like pills and prescriptions and doctor's appointments, but are more things like your wheelchair or more things like your uh, aid or vocational supports or all the things that the regional center pays for. Um, and can you talk more about the scope of the Medicaid program and what cutting it back means that goes beyond the healthcare services?
So, Clarissa, this is an excellent point. Again, Medicaid is a healthcare program. It's gonna pay for primary care, specialists, medications, some hospital visits. But in addition, Medicaid is truly the only payer for home and community-based services. And home and community-based services alone can encompass many different things. Medicaid home and community-based services waivers encompass job coaches for people with disabilities, including people with disabilities in customized employment. It Medicaid waivers cover things like community mental health programs and diversion programs, again, vocational training, personal assistance services, community aids, and more. Medicaid also provides supports for students with disabilities in school through the ETPSD, and I cannot remember what that stands for right now. Um, there is such a broad range of services covered by Medicaid that really are not replicated by any other aspect of our healthcare system, in part because these services often are um, performed and conducted in places where people already are, whether it's their homes or their schools or other community locations. So, for example, people with disabilities are not having to figure out how to coordinate accessible communication to go to a hospital or a medical center, a place where they don't go every day in order to get these services and are more likely to use them because, again, they're where we already are. Um, Medicaid also um, again, like pays for the the wages of direct support workers, which include personal care attendants, home health aides, nurses, LPNs, and others. So that workforce, Medicaid is it really means their jobs and their livelihoods. So one of the biggest issues within the Medicaid system is that home and community-based services are optional. They are not a required service of Medicaid. Institutional care is required. States must provide those options to citizens. And so because home and community-based services are optional services, they are often the first to get cut when states are facing a budget crisis or shortfall. So, the cuts within HR 1 are awful. And even before those cuts take effect, we are seeing states that have budget gaps begin to cut home and community-based services. And we're seeing it in states like Maryland, where their developmental disability Medicaid waiver is facing hundreds of millions of dollars of cuts, and families are engaged in incredible advocacy to try to prevent that. We're seeing it in states like New York, which is using a different system to manage their consumer-directed home and community-based services program, which will result in loss of services and supports for people with disabilities living in the community. We're seeing it in states like Idaho, where folks are, again, also really fighting back. And this is before the HR 1 cuts take effect, before Medicaid loses close to $1 trillion.
I think when you start to really, I mean, some of this legislation was put in into law, and I think a lot of times people have a difficult time understanding the unintended consequences. They see it very high level. Well, if you're getting healthcare and you can work, you should. But when you start to lay out all the implications, it's a lot more complicated. And one implication um, that occurred to me as you were speaking was if people if there aren't jobs available for people, and there's a huge influx of people who need to meet these requirements to stay healthy, that it's going to put a lot of pressure on the community college system because you can meet this requirement through being a half-time student. Community colleges were already under a lot of pressure from sort of fake students that were enrolling for to get student aid. And in some cases, people, some community colleges, more than half their applicants and people that they enrolled were sort of fake students. And I can imagine this creating a lot more fake students who aren't really working towards a degree or working towards
Right.
a job goal, but are merely enrolled for the purposes of meeting this requirement. Are there, can you speak to that or implications on other?
I can't speak to that, but you know, from a workforce perspective, we like there are many, many employers who have done a great job becoming inclusive, accommodating employers for people with disabilities, and there are likely more who have not. And so, even if there becomes this great job boon and we see an unprecedented increase in disability employment as a result of these work requirements, it will not be long lasting. What we know to be true is that for many people with disabilities, they can get a job and then struggle to keep that job because accommodations are not met or the employer does not understand how to meet the disabled employee kind of where they're at based on their communication needs or their neurotype. And so they lose the job quickly. And that causes this cascade effect of loss of benefits, loss of supports. Um, and so I'm worried about seeing more of that, where again, people will try to get a job, it will be short-lived and cause far more harm than good in the long run. One of the questions I have about the education component is that many people with disabilities are in school, but they are not enrolled in a program that ultimately provides a meaningful or an accepted credential. And so I don't know if students in those programs will be able to fulfill the education requirement. We don't have clarity on that yet.
Thank you so much. Well, there's a lot to think about, and I'm glad that we are starting early to think about it so that we can make sure that the people making decisions about whether and how to implement this law can think it through, and we can help them to think it through and think about all the implications. Thank you so much. I deeply appreciate your being here with us today.
Thank you so much, Clarissa, for having me, and thank you everyone for being on this webinar.